Good morning, everyone. I'm Martha Zavala, President of the League of Women Voters, Pasadena area. Welcome to Thursday with the League, Outwitting the Virus, which I hope that's something we're all going to be working toward. Before we get to our program, I would like us to take a moment to acknowledge Black History Month and the many contributions of the Black community. As the League of Women Voters, we honor the Black activists whose sacrifices have resulted in advancing voting rights and civil rights for all of us. And so we also want to thank those who continue to do this work through the Black Lives Matter movement that sheds a light on the disparate treatment that continues to plague all people of color. And so thank you very much for that and for advancing all of us in civil rights, social justice, and all of the things that are important to our organization. And now I would like to get started with today's program. We had a little bit of a hiccup, but we're here now. And I know you're all ready to hear the good news, or at least the latest news about combating the virus. I know that today's presentation, is brought to you by the League of Women Voters Pasadena area, our healthcare committee. The healthcare committee happens to be blessed as our entire league to have two co-chairs for that committee, and both of them are doctors. The co-chairs are Doctors Thad and Margan Zajdowicz. Thad and Margan are both infectious disease physicians and epidemiologists, I practice saying that, with extensive experience between them in infectious diseases, epidemiology, public health, pandemic disease planning, vaccines, and vaccine clinical trials. So we're very proud to claim them as members of the League of Women Voters Pasadena area. And now we will hear first in this program from Margan, and then we will hear from Thad. We're going to have a question and answer period, but not until the end of their presentations. I know that many of you submitted questions prior to today, and they're going to make every effort to answer all of those. But we also have our question and answer period, that feature open on this webinar. Please don't use the chat. You can say hi to everybody if you'd like through the chat process. But if you have a question for our panelists, please submit them in the Q&A feature. That way they'll be sure to see them and make an effort to take those in consideration. So again, all the questions will be answered at the end of their presentation, and then they'll pick up as many as you entered today. So be sure to submit those questions if you have them as soon as you think of them. They'll be collecting them and sifting through them and see what they can respond to right away. So anyway, I want to thank Pasadena Media for all of you attending. It is being recorded, and then they're going to upload that to the YouTube channel that we have, and you can access that through the League of Women Voters Pasadena area website. And you'll be able to share this with however many people you're in contact with. This is one of the most important things that we do, is to offer our information to everyone so that they can get some use out of it. And now, the reason why we are all here, please welcome Doctors Margan and Thad Zajdowicz. Thank you.
Thank you, Martha. As Martha mentioned, Thad and I are the co-chairs of the Healthcare Committee, and we have dedicated our efforts to advocating for universal healthcare. We follow legislation with regard to healthcare. We had been addressing the topic of racial disparities in healthcare, but just as we launched that, we got slammed with this pandemic. And so we have turned our attention, at least for the moment, to issues surrounding the pandemic. I want to let you know what the format will be. And the format of the talk is in two parts. And I will go first, as you can see, and I'm going to discuss where we stand with regard to the pandemic right now. I'm going to talk about variants. I'm going to talk about monoclonal antibodies, and I'm going to talk about long-haul COVID. And then I'm going to turn this over to Thad, who's going to address vaccines and vaccine distribution. And he's going to talk a bit about what we can expect in the future. And then, as Martha indicated, we're going to have a Q&A session at the end for your questions. Okay, the title of this talk is In a Race with Us versus the vaccine. And it's at this point not really clear who's going to win this race. But obviously it's important for us to outwit this. And we are in very unusual times right now, very unsettled times. And as I sort of thought about what analogy I could make, this is the analogy that came to mind. It's been used a lot, but it is really the best of times and it is the worst of times. And we've seen a fair amount of wisdom and we've seen a fair amount of foolishness. We've seen belief and we've seen incredulity, and we are hoping for a spring of hope, but we've certainly had a winter of despair. I think everybody is familiar with Dr. Fauci. Dr. Fauci is an infectious disease icon. Thad and I had the good fortune to practice infectious disease in the broad environment where Dr. Fauci was. And so we got to interact with him and know him. And somebody put together this Fauci scale in November. And in November, Dr. Fauci spent a lot of time in these spots on the Fauci scale where he didn't look entirely happy. On the other hand, we do understand why he wasn't so happy. And this is a graph of the daily number of deaths in Los Angeles County, starting back in March and going all the way through December. And you can see that no deaths are good. But as we approached the fall, September and October, things began to look a little bit better. And then we had skyrocketing deaths. And this probably relates to a variety of things, which include the holidays, that is Thanksgiving and Christmas, where people got together and gathered, and also relates to a substantial amount of pandemic fatigue that set in. And what this means is, this is a headline from the Los Angeles Times from the 1st of February, where they point out that January was the pandemic's deadliest month in the state of California. So these were indeed dark times. And when you have dark times, you have to turn to some difficult measures, and those include rationing of care. Ambulance crews were told not to transport patients who had a poor chance of survival. The EMS folks were rationing oxygen because there was an oxygen shortage, and they were told to maintain oxygen saturations in patients at 90% or less. Normal is 94% and above. And some of you may remember that the air quality restrictions in Los Angeles County were lifted because there were so many cremations that were going on, because there were so many bodies that needed to be disposed of, that we couldn't maintain appropriate air quality. And recent data have emerged, been published, that demonstrated something that we kind of already knew, and that is that when you stress your healthcare system, and particularly when you stress your intensive care units, mortality is going to increase, and that has now been clearly documented. So these were indeed desperate times. We now find ourselves in February of 2021, and the people that put together the Fauci scale have expanded it to 9 spots on the scale. And fortunately, Dr. Fauci is spending more time at the left-hand side of the scale, which means that he's looking significantly happier for a variety of reasons, not the least of which is that we are now launched on a plan that takes good science into account. The other reason that he's probably looking a little bit happier is that when you look at the nationwide COVID-19 metrics, you can see that things are getting a bit better. These are the daily cases up to January 27th, and the number of cases has started to fall. And when you look at the patients who are currently hospitalized, that is also starting to fall. And when you look at deaths, we hope the deaths are going to start to fall. This demonstrates a classic fact about the epidemiology of this pandemic, and that is that the front end, the leading indicators are the cases. And so when you have improvement, you see that first in the cases. And it usually takes about a week or something like that for people to be hospitalized. And so the fall in patients who are hospitalized is less than the number of cases. And then the lagging indicator is always the number of deaths, because between hospitalization and deaths, there's usually 2 to 3 weeks. And so you will not see the decline in the deaths so soon. This is a graph of the new daily cases from February 2nd in California, taken from the Johns Hopkins Coronavirus Resource Center. And you can see, in fact, we are having a substantial decrease in the number of cases, which is truly good news. And then when you look at the deaths, they are beginning to trend downward in Los Angeles County. So this is where we stand currently, both globally, nationally, and in the state and locally. And these data were taken from February 2nd. Worldwide, we reached the 100 million cases mark with 2.2 million deaths. We have 26 million cases in the US, and I saw this morning that this number is now 451,000 deaths. It's very clear that probably by mid-February, we're going to reach the 500,000 mark with regard to deaths in the United States. 3.3 million Californians have been infected with 41,000 deaths. And in Los Angeles County, we also eclipsed the 1 million mark with nearly 17,000 deaths in Los Angeles County to date. And right now we have in excess of 5,000 people who are hospitalized with COVID-19 in LA County, and more than a quarter of them are in the ICU. Now, on the good news side, vaccines have arrived in Los Angeles County, and almost 800,000 doses of vaccine have been given. You can see that the vast majority of them are, in fact, the first dose, and the number of people who have received their second dose as of January 25th is relatively small compared to the population of Los Angeles County, which is about 10 million. So somewhere slightly in excess of 1% of the people have received their second dose as of the 25th. Now, that's the good news. The bad news is that there are some bad things that have arisen, and that is in the form of variants. And variants are forms of the virus that have undergone mutation and perhaps changed their characteristics a bit. The most widely prevalent variant is B117. And you can ask the question, do these variants matter? And the answer is yes, indeed they do. And in order to understand what this means, we have to go back and look at the coronavirus and how it operates. I think everybody is familiar with this model by now, but these, of course, are the spike proteins that are the kind of, in a way, the business end of this virus, where it attaches to the host cell via the ACE2 receptor site. And the replication of this virus takes place right here with the RNA. This is an RNA virus. And this is what gets replicated when the virus attacks a new host. Now, so viruses, for all intents and purposes, are divided into RNA viruses and DNA viruses. And RNA viruses are well known for their proclivity to mutate. Interestingly, this particular coronavirus is not the worst mutator. It is a relatively stable RNA virus by comparison, but it is clearly undergoing mutation because the pandemic is or has been really pretty much out of control. And these mutations arise as a natural byproduct of viral replication. They tend to be correlated with the possibility of increased virulence, and they are certainly the way the virus evolves. The variations will arise also depending on natural selection and the pressures that we put on the virus. And when we are starting to vaccinate people, or we have herd immunity, or we take non-pharmaceutical interventions, we are exerting pressures on this virus. Some of these mutations are helpful to the virus. Most of them are of no consequence one way or the other. They're neutral. And occasionally it sustains mutations that are harmful to the virus. The rapid mutation rates allow the virus to survive in novel hosts. And we are, in fact, a novel host. That is, humans are. Prior to somewhere around the fall of 2019, we were not known to be a host for this virus. And so the virus had to adapt in order to be successful at replication in us as hosts. Now, these rapid mutation rates also have the potential to overcome vaccine-induced immunity, and that obviously is a potential problem. And they also are likely to evolve such that the virus is able to escape disease resistance. And when you talk about disease resistance, there are all kinds of disease resistance. That includes herd immunity, that includes natural immunity, that includes whatever we do to diminish transmission. And a really important point is that a mutation that produces increased transmissibility is more advantageous to the virus than one that induces more lethality. And that is because it's not in the virus' best interest to kill its host, because no replication takes place at that point. And this is exemplified, for instance, by the Ebola virus, which is quite lethal, and because many of the hosts simply die. Now, this brings us to the big new variant, which is B.1.1.7. It was detected first in the United Kingdom, and it was detected because they had a surge of cases in Kent in December. And the Brits are very good at genomic surveillance, and they sequenced the virus that was causing this surge and found that it had 23 new mutations. 17 of them appear to have occurred all at once, and 8 of them were in the gene that encodes the spike protein, which makes a lot of sense, actually, because, as we said, that's kind of the attachment end of this virus, and it's clear that these 8 mutations conferred an advantage. And within 2 weeks, this variant had spread to the rest of Britain and elsewhere in Europe. And unfortunately, it was also detected that these new mutations imparted somewhere between a 50 and a 70% increase in transmissibility. And so B.1.1.7 is now found in multiple countries and really in multiple states, including California, throughout the US. So this does constitute not good news. It means the variant is more transmissible, maybe a lot more, and this has great consequences for the control of the pandemic. And you can look at the explosion of the pandemic in mathematical terms, and this variant adds somewhere between 0.36 and 0.68 to the reproductive rate, or the R, of this virus, meaning that on average, it infects an extra 0.36 to 0.68 persons compared to the original virus. And that may not look like a lot, but when you think about all the replication that's going on and all the transmission among millions and millions of people, this is huge. So this constitutes exponential growth. And a variant with increased transmissibility is indeed worse, as I'd already indicated, than a variant with increased severity of disease. From a mathematical function point of view, something that is more deadly is linear in function, but something that is more transmissible is exponential in function. So this leaves us with a lot of uncertainties with regard to variants. Does this variant cause more severe disease? Can this variant reinfect people more easily? That is, infect people who've already had COVID-19. Can this variant circumvent vaccine or disease-induced immunity? And unfortunately, this is not the only variant. There are some others that have arisen. There is a variant B1351 from South Africa, which has demonstrated both in vitro and in vivo evidence of possible immune escape, and we will talk about immune escape. In vitro refers to the lab, and in vivo refers to in humans. And this South African variant has now been identified in South Carolina and in Maryland. There is the variant P1, which is in Brazil, which I will talk about in another slide. And then we have our own California variant, which was detected in California in May by genomic surveillance at UCSF and Cedars-Sinai. And to give you an idea of how fast it can spread, in December, it was present in 3.8% of the samples, but by January, it was present in a quarter of all the samples, and it is now widespread throughout California. And some of you may have read about the super spreader event that occurred in San Jose in a Kaiser hospital in an emergency room that was traced back to an air-powered Christmas tree costume, which somebody wore in the emergency room to try to cheer up the healthcare providers. But the end result was it created a super spreader event with this particular variant. Now, I alluded to immune escape, and immune escape is a significant problem. Immune escape occurs when you have mutations among the variants that are sufficient to allow the virus to evade naturally induced or vaccine-induced immunity. And this immune escape may be complete or it may be partial. And it's instructive to look at what happened in Manaus in Brazil, which is the source of this P1 variant. Manaus is the capital of the Amazonas state in Brazil, and they had had a very serious outbreak of the original virus, where it was estimated that 75% of the people in their city had been infected. They had a huge number of deaths. And this picture demonstrates the mass graves that were dug there to bury people. And they thought that they probably had achieved herd immunity and that they probably had experienced the worst of this pandemic. And unfortunately, that turned out not to be the case. They detected a new surge, which started filling their hospitals, and they did genetic sequencing of that virus. And they detected a new viral lineage, as I said, which is P1. And that demonstrated that people, based on the new viral lineage, were susceptible to reinfection, that this was allowing immune escape and was going to require vaccine updates. And this is, as you can see, is relatively new data. Now, this is kind of a terrifying looking slide, but actually it's not so bad. We have up here at the top the three variants that I've already talked about. This one from the UK, this one from South Africa, and this one from Brazil. And you can see the mutations that they have sustained. And you can see that all of them have mutations in the spike protein. And there are three characteristics here that are very important to pay attention to. They are transmissibility, and this means change. They are lethality, change, or immune escape. And I pulled this off of Twitter on January 24th, and I have had to update it virtually every day since then. This is from the La Jolla Institute of Immunology, because things have literally changed day by day. And so the bottom line is that this is the B117 that does indeed have increased transmissibility. Boris Johnson suggested in a press conference that the Brits believe that it also has increased lethality. There is a brand new report that suggests that immune escape is probable, at least to some extent, with this variant. And that's because this variant just acquired this mutation right here. So this one has that there is some element of immune escape in any variant that carries it. This one has it as well. Now, another indication that there is a problem with immune escape is that Novavax and Johnson & Johnson, looking at their vaccines, have announced that they have detected decreased efficacy of their vaccines with the South African variant here. So this does begin to suggest that with our current vaccine, we are not completely out of the woods. This is a report on the 25th of January that demonstrates that this Brazil variant has now entered the United States. This is from the Minnesota Department of Health. And so no one should conclude that based on the international occurrence of these variants that we will not be affected by this. On the 28th of January, the Public Health Department in South Carolina announced the detection of the South African variant here in the United States. And on the 30th of January, the health officials in Maryland announced the detection of the South African COVID variant in Maryland. So we can assume that all these variants are going to be present in the United States and very soon. So the question arises, mission. As long as you have uncontrolled viral transmission, which then leads to uncontrolled viral replication, you will continue to have the emergence of these variants. So what does this mean? We are definitely not yet out of the woods. And there are very credible infectious disease epidemiologists who are predicting that we're going to have another big surge of cases before we control this virus. It's predicted that that big surge may occur in the month of March. The good news is that current data do suggest that the vaccines that we are currently deploying continue to prevent severe illness and death, and that's certainly incredibly important. As I indicated, we should assume these variants will be widely distributed. There is already work ongoing to formulate new vaccines to incorporate the new variants. And the good news is that particularly with messenger RNA vaccines, it's not too difficult to formulate a new vaccine. You simply insert the new messenger RNA. But it does say that we all need to be very cautious about throwing off the pandemic restraints. So how do we stop viral transmission? And this slide is really intended for people primarily who have not been fully vaccinated. But we all need to double down on non-pharmaceutical interventions, or NPIs. And what that means is that we need better masks. We need to be using N95s, which are very difficult to get and are pretty much reserved for healthcare workers. But KF-N94s and KN95 masks are not so difficult to obtain. They can be ordered from Amazon. And at a minimum, everybody needs to double mask, which can be something as simple as putting a good cloth mask over a surgical mask. But masking should involve at least 2 to 3 layers. People should not be spending time indoors with people not in your household. They should not be going to the grocery store. They should not be getting a haircut. They should not be riding in a car with someone other than in their own household. Ventilation is incredibly important because it disperses the aerosols. And people should not be traveling unless it's absolutely essential. And very importantly, everybody should get vaccinated as soon as possible. And Thad and I were lucky enough to get our second dose yesterday. Now, a question that we get a lot is, if I am fully vaccinated and more than 2 weeks out from my second dose, what can I do? And what you should do is still wear your masks always when you're out in public. And then beyond that, everybody has to make prudent and rational decisions about their own exposures and their own sense of risk and their own concern about exposing others. And obviously, it's really important not to expose others. And of course, the question of whether or not a fully immunized person can transmit this virus to somebody who is not vaccinated is not completely answered, although the good news is that there are some data that suggest that there's certainly diminished transmission under those circumstances. But the question is, could you get a haircut if both people are fully vaccinated? The answer, at least in my mind, is probably. Masks should be worn. Can you hug your family or hang out if all are vaccinated? Well, probably. Can you hug your family and hang out with masks on if they are not yet fully vaccinated? Well, you certainly ought to have your masks on if they're not fully vaccinated because of the threat of transmitting virus to them, even though you are immunized. Can you go to the dentist? Yes, you probably should go to the dentist if you need dental care. If you're fully vaccinated, the dentist is also probably vaccinated and is certainly going to be using PPE. Should you get postponed medical care? The answer is yes. Postponing medical care, obviously you don't do well over time. If you're going to go to Trader Joe's or Gelson's or Vaughn's or Ralph's, you absolutely have to have a mask on and you should be socially distanced. And if you want to travel and you're fully vaccinated and you're more than 2 weeks out, you need to travel judiciously and with masks on at all times. But the good news is, if you are fully vaccinated and you're more than 2 weeks out, you can feel somewhat relieved. And that takes us back to this famous model, the Swiss cheese model of respiratory virus pandemic defense, which in which every one of these planes is a defense against this coronavirus reaching you at the other end. And the presence of vaccine really does add substantially to your defenses against this virus. So all is not lost. Now, I'd like to turn our attention to the treatment of outpatient coronavirus disease, COVID-19, because I think that this is something that probably has not gotten as much attention as it should. And I think it's important for people who are not vaccinated, who have the misfortune to get COVID-19, to be aware that there is treatment available. And in November, the FDA authorized monoclonal antibody treatment under an EUA, the Emergency Use Authorization, for the treatment of COVID-19. And these are monoclonal antibodies for mild or to moderate outpatient disease. These are not patients who are hospitalized. And these monoclonal antibodies are designed to stop the viral entry into the host cells, that is, into the cells of the person who has just become infected. There are two forms of this. Eli Lilly makes a single monoclonal antibody. They all have these horrible names. But when they end in MAB, that tells you it's a monoclonal antibody. And Regeneron makes a cocktail of two antibodies of these two. Some of you may recognize this. This is the cocktail that former President Donald Trump got at Walter Reed when he contracted COVID-19. And although I probably cannot say that it saved his life, I do think that it probably prevented him from being in the ICU and going to getting on a ventilator. Both of these are authorized under emergency use authorization for high-risk patients who are expected to progress to hospitalization. And high-risk patients means people over the ages of 65 and people who have underlying significant medical issues. And what they do is they produce a rapid reduction in viral load and a decreased need for further medical care. Now, you might ask the question, well, why aren't they used more? These medications are available. Um, and the answer is they're somewhat cumbersome. It's not as if you can at any time take a prescription and go to the drugstore and get a prescription for this. The patient has to be treated as soon as possible after diagnosis. That needs to be at least within 10 days and preferably within 3. And they're treated with a single IV infusion over 60 minutes that must be medically attended. So this is not something that you do at home. And so the point in showing you this is if you have not been vaccinated, or you have family members or friends who have not been vaccinated and acquire COVID-19, this is something that they should contact their private physician about, because it has the potential to make a big difference. And in fact, these monoclonal antibodies have been looked at in terms of preventing COVID-19 disease in long-term care facilities. And I don't want to dwell on this, but these are new data from January 21st, not yet peer-reviewed or published. But it appears that even an infusion of this particular monoclonal antibody can prevent COVID-19 in skilled nursing facilities or long-term care facilities quite well. And this is a press release from January 26 that showed some further good news, and that is this was treatment with Lilly monoclonal antibody here combined with another one that they had, reduced the risk of COVID-19 hospitalization and death by 70%. That's a lot. And so there is real good news with regard to monoclonal antibodies, and we should not forget them. Now, this is not to give you a lesson in how you make monoclonal antibodies, but I want to make a point here. Monoclonal antibodies start with the injection of an antigen into a mouse, and the mouse's spleen is harvested and then is fused with human myeloma cells. Those are immortal cancer cells, to produce hybrid cells, which are in fact immortal and are expressing human antibodies to the antigen that was injected here. And you can select a single clone that's making the antibody that you want, and it's purified, and that's how you get monoclonal antibodies. And the reason I tell you this is that monoclonal antibodies are dependent on what antigen you immunize the mouse with. So that if we use the original variant, you're going to get antibodies against the original variant. If we have B117 or P1 or whatever, we're going to have to go back and make new monoclonal antibodies, because the ones that were made using the original variant are not going to be effective. Now, the other thing I wanted to talk about, because I think it has probably not gotten as much attention as it should have, and maybe would be helpful to be part of the messaging, is the problem of long-haul COVID. And I see a lot of comments about COVID-19 is just a bad cold, or it's just like flu. Why are we all worked up about it? And so I think it's really important to look at the longer-term sequelae, the longer-term complications of having COVID-19. And these are data from the CDC from way back in the summer, where it started to be appreciated that people who got mild outpatient COVID-19 maybe didn't turn around and return to their previous state of health as quickly as we might have hoped. This was a survey of symptomatic adults following a positive test. And at 14 to 21 days, 35% of them had not returned to their usual state of health. And 20% of the patients who were surveyed, who were ages 18 to 24 and previously healthy, were not doing well at 14 to 21 days. And nearly half of the patients who were 50 years of age or greater were still struggling with this illness. So that began to tell us that there's really a problem here. Older age and multiple medical conditions were associated with prolonged illness. There was no association with race or ethnicity. And the symptoms that were most likely to persist were fatigue, cough, shortness of breath, what's known as brain fog, where your brain doesn't seem to be functioning very well and you have troubles with short-term memory, Prolonged COVID-19 was associated with obesity and prior psychiatric illness and with being female. And this was in stark contrast to influenza, where more than 90% of outpatients with influenza will recover within 2 weeks and return to their previous state of health. Now, there are longer-term issues with COVID-19, and this is a fairly famous study from Wuhan, where they did a 6-month follow-up. It was published in Lancet in January, and they looked at people who had had COVID-19 6 months previously, and more than 3/4 of them had at least one symptom persisting. That was frequently fatigue and muscle weakness. There were people with sleep difficulties, anxiety, depression. When you looked at their chest, either their chest X-ray or their chest CTs, more than 50% of them had abnormal chest imaging, and a number of them had decline in kidney function. And I don't know how many of you saw the New York Times Magazine from January 24th, but this was the cover of it. It's quite depressing. What if you never get better from COVID-19? Infectious disease physicians know that what's known as chronic fatigue syndrome or myalgic encephalomyelitis following other viruses, viral infections. And so it's beginning to look like there are some really long-term COVID issues associated with this virus. Up here, we have normal lung, we have a smoker's lung, and we have a COVID lung. You can see that this is what it ought to look like, and that's what COVID lung looks like. As I've indicated, there are problems in the brain. There are certainly problems in heart tissue, heart muscle. And this is a nice schematic of all the organ systems that are affected by coronavirus, the SARS-CoV-2 infection. This is an alveolar sac in the lung that is being destroyed by the coronavirus. This virus attacks small vessels and heart muscles and produces clots. The brain infection is a matter of some controversy, whether it's direct or it's related to the small vessel disease here, but it produces strokes, seizures, and confusion. We already know that it attacks the nose because we know that people frequently lose their sense of smell, and that this indicates that the nose's nerve endings have been damaged, and probably all the way up to the olfactory nerve. And sometimes this gets better with time, and sometimes it doesn't. We know that the liver is infected. We know that the kidneys are infected. And we know that there are a lot of ACE2 receptor sites in the lower gastrointestinal tract. So a lot of patients have diarrhea. Now, this is a report that came out just in the last couple of days. It's a study from Boston University of admittedly a very few number of patients, 9 patients, suggesting that this infection triggers antibodies that attack a wide range of the patient's own tissues. That's known as autoimmune disease. These antibodies may persist for months, and this may explain some of the lingering symptoms. I should caution everybody that this has not yet been peer-reviewed or published, but there are prior papers that are published that do hint at this possibility. This is a scanning electron micrograph of a human cell. It's not usually blue, they've colored it blue, but these green particles are in fact SARS-CoV-2 coronavirus. And it's from a credible source. This is a Hopkins hospital here. And this is linking new cases of diabetes to COVID-19 disease. About 14% of those with severe COVID developed a form of either type 1 or type 2 diabetes. This needs validation and further study, but this is also not a good sign. And it suggests that the coronavirus has invaded the islet cells in the pancreas and is at least damaging or perhaps destroying them. So what are the take-home messages here? They are, don't get COVID-19 if you can possibly avoid it. And Margan and Thad have been hiding out in their apartment for more than a year now. You should get your vaccine as soon as possible, and you should take whichever vaccine you are offered. There's probably no point in trying to parse out which vaccine would be more efficacious. Don't let your guard down after the first or second dose. You are not fully immune until 7 to 14 days after the second dose. So we are waiting for February 13th or February 20th when we will be fully immune, hopefully. You should intensify your non-pharmaceutical interventions with better masks, stay away from other people, and good ventilation. And very unfortunately, we all have to wrap our minds around the idea that we're going to be dealing with this for a good while more. Even after you're vaccinated, wear a mask, keep your distance, and especially when you are among those who are not vaccinated. We all need to be aware of the variants and their characteristics, and it's very likely that they will change the landscape. And it's also very likely that booster doses or different vaccines are likely in our future. So to return to Dr. Fauci is a much happier man because science has returned to our approach to looking after this pandemic. And at this point, I will stop sharing and return the presentation over to Thad.
Okay, let me bring my slides up here. Hang on. There we go. Okay, I'm going to finish up talking about vaccines and vaccine distribution, trying to build on what Margan said. But before I start, I would like to thank all the members of our healthcare committee. Margan and I work with a really good group of people on our healthcare committee. And it's been fun working with them over the past several years. So just to reiterate, you have seen this type of graph many times. This particular graph shows the cases since the beginning of this pandemic in the United States compared to Europe, South America, other continents and countries. The United States has the dubious distinction of being the world leader for coronavirus cases, not a great distinction. Margan showed you this Swiss cheese model. I'm going to talk about primarily this last slice, but it doesn't make any of the other slices any the less important. They're very, very important to control this pandemic, even with the advent of vaccines. We need to remember that there are always mice that are nibbling around the edges of these various interventions. For example, and the mouse probably ought to better be down here on the masks, because we all know that masking has become politicized, and that's unfortunate because there are strong data that show that masking does reduce transmission of COVID-19. Now, for those of you who are not immunologists and vaccinologists and whatnot, but you've all received vaccines, vaccines basically introduce a weakened or inactivated form of a pathogen, a virus or a bacteria, into the body. We'll talk about how that's done a little bit as I go forward with coronavirus, COVID-19. Your own immune system then produces antibodies to defend against that particular pathogen, whether it's a virus or a bacteria. And in the absence of being exposed to the native infection, to the actual coronavirus itself, your immune system is now kind of primed and sitting there ready to go and waiting, so that when you are exposed, your immune system wakes up, it will enhance your body's natural defenses, recognize that there is an invader, and deal with it. Now, Margan showed you a similar cartoon. Hers was a little bit more elaborate, but just to reiterate, the nasty stuff in the virus is its genetic material, in this case, what's called RNA. And a specific part of that RNA, the spike protein gene, allows for this virus to have protein spikes on its surface that then allow a virus to attach and enter a cell where it can replicate and produce more viruses. So this becomes the target really in the end, either these spikes themselves, or as we'll see, the protein, the spike protein gene, the messenger RNA that produces those protein spikes. So we currently have a whole bunch of vaccines that are either available, two of them right now, the Pfizer-BioNTech and the Moderna vaccine, which are messenger RNA vaccines. We have two others that are approaching, in the United States, are approaching emergency use authorization, the Johnson & Johnson vaccine and the AstraZeneca vaccine. The bottom line here for these is they use an adenovirus vector, which is a respiratory virus that has been engineered so that it itself does not replicate, but it delivers the message for the messenger RNA into your cell so that the cells can produce the spike protein for your immune system to recognize. And there is a protein vaccine called from the firm Novavax in Maryland. It's an interesting vaccine, but it'll probably be several months more before it attains emergency use authorization. Now, the data for these vaccines came out in December, late November, December, and it was phenomenal. This is not only what I would call a home run in vaccines, this is a grand slam times several. When the Pfizer vaccine results of the trial were released, what was seen was very interesting. And this part here is expanded in this little box. And by the time you reached about 10 to 12 days after you received the first dose, the priming dose, people who actually received the vaccine were already showing protection against COVID-19. And that protection extended for the entire duration of the trial, as opposed to those who did not receive the vaccine. They received the placebo, and they indeed were as susceptible to COVID-19 as any unvaccinated person. And in fact, when that when those trial data are compared with the Moderna trial, the Moderna vaccine, you see exactly the same thing. Now, these two vaccines, just to put it in perspective, use messenger RNA as to target the cells to make spike protein for the immune system to recognize. The Chinese scientists at the beginning of the pandemic actually took the virus and determined its genetic sequencing, determined where the gene was for the spike protein, shared that online, and within 5 days, the Vaccine Research Center at NIH in Bethesda, Maryland, had, in essence, sequenced that and began the road to a vaccine. That's 5 days, not 5 years. Now, the Johnson & Johnson vaccine, their full data for their phase 3 trial is not available yet. It should come out hopefully within the next week. But in their earlier trials, what were called phase 1/2A, what they showed in both a young cohort of 18 to 55 years of age and an older cohort greater than 65 years of age, if those cohorts received placebo, there was no immune response that was generated. Regardless of dose or timing, if an active vaccine was given both to younger and older people, you can see significant immune response, immunoglobulin, that was produced by that vaccine. So the adenovirus vaccines like Johnson & Johnson and AstraZeneca, they work and they're highly effective. They also produce, and I could only find this one slide, and it's not a great slide, but I put it up to point out something that's important. The immune system has two basic arms. One is to produce antibodies, and the other is to produce cells that both recognize the pathogen when it is introduced to the body. They recognize the coronavirus, and they also provide memory to your immune system. And what was shown was that those memory cells, as well as the cells that are associated with actually killing the virus, are both stimulated by the Johnson & Johnson vaccine. The same is true for the Moderna and the Pfizer vaccines as well. Now, some people have worried, and we saw some questions coming along. Well, what are the side effects of this vaccine? I received a vaccine, and we frequently hear this business of, well, I got my flu vaccine and I got the flu. Well, first of all, you don't get the flu from flu vaccine, and you don't get COVID-19 from the vaccine either. These vaccines are, again, do not contain live virus. They do not contain anything that can produce infection. Anaphylaxis was raised as a question with the Pfizer vaccine relatively early on after it began to be used. But this slide helps you to, I think, to put it in perspective. When this slide was made, and now this is 450,000 people as of this morning, deaths from COVID-19 were 410,000, now 450,000. 1 in every 800 people in the United States had died as a consequence of COVID-19. When you look at anaphylaxis, death from anaphylaxis has not been seen with the COVID-19 messenger RNA vaccines. And in fact, you see only about 1 case per 100,000 of anaphylaxis, which is treatable with these vaccines. That's a little bit more than you see with giving IV penicillin, which is about 1 per million. But it's a lot less than giving IV contrast media, which is what you get when you have a CT scan, for example, and they squirt the contrast media into you, where there's a significant risk from anaphylaxis, significant in the sense that it's 1 per million. It's still, the betting odds were when I needed CT scans that I signed for the permission because I knew this. And the IV contrast media anaphylaxis rate is 1 to 4 per 100,000. So the vaccines are safe. And when we look at the vaccine safety profile from the trials, the side effects such as pain at the injection site, headache, and so forth, flu-like symptoms, were no different really with these vaccines than with any others. And it's important to show, this is in these trials that have been done with the 5 vaccines I mentioned when this slide was made, and this is a somewhat older slide looking at 74,000 people that had received the vaccine. Of those people that received the vaccine, none had COVID hospitalizations, none had died from COVID, and none had died because of the vaccine. These are safe vaccines. It's also important to remember that life happens. And as we go along, and if we look at 10 million people chosen out of random of the American population, and we vaccinate them and we follow them for 2 months, of those 10 million people, 4,000 plus will have a heart attack, about 4,000 will have a stroke. You can see the other numbers, and about 14,000 of those people will die. That's called life. These things happen all the time, whether you're vaccinated or not. And there's simply no data to show that the vaccines produce significant harm in any way. Now, when this pandemic came along, over at the left-hand side of the slide, we all got together and most of us followed the program and we stayed at home and we used masks and social distancing. And believe me, we all got pandemic fatigue. And along came news that we now had vaccines with 95% efficacy after less than a year of development and testing. At the same time, unfortunately, the vaccines got announced in the November-December timeframe. We had the 3rd and highest surge in the United States, producing worst pandemic vaccine. And then by mid-December, we started to give these vaccines in the wider population. So we went from bottom to top to bottom to top. But now the poor vaccine rollout has sort of created a little bit of concern again. So we're at a valley, so to speak. And as we come up with getting vaccines rolled out, as Margan talked about, we have to consider these variants such as B.1.1.7 and others that are spreading in the population. I updated this slide as of last night. These are the data from CDC. We have allocated 55, almost 56 million doses of vaccine across the United States. Of those, 33 million of those doses were administered as of 6 o'clock yesterday morning. 27 million plus people have received one or more doses. And what that means is we have finally crossed the threshold with more people being vaccinated than were confirmed with the diagnosis of COVID-19. I think that is indeed evidence of progress. Of those, unfortunately, we have only 6.5 million people approximately who've received 2 doses and therefore are considered completely immune. When you look in California, and these are data again as of yesterday, we've given 9.6 doses per 100 people in California on the whole. Overall, this means that 7.7% of the population got at least one shot, and we have about 1.6% of the population in California that's fully vaccinated. So we have a long way to go. I wanted to show this slide because there was a lot of discussion about how these vaccines were developed and made. You all heard about Operation Warp Speed, which was and is a government program that in essence did something very good. Vaccines are an iffy business. If you don't hit home runs like these vaccines seem to have done, you can spend a lot of money as a manufacturer and lose a lot of money because it never gets approved for anything. So the government contracted with the pharmaceutical companies to manufacture the vaccines, and they told them, we'll pay you to make the vaccine now, even if your vaccine isn't approved. So we covered, when I say we the citizens covered the cost of the production of these vaccines even before we knew that they would be licensed, or not licensed, excuse me, but approved under emergency use by regulatory authorities to be used. At the same time, we had to produce a lot of other things, such as syringes, vials, and whatnot, because you can't, in essence, give the vaccines, as we'll see, without having something to give them with. So those ancillary supplies and PPE, personal protective equipment, had to be, production of them had to be ramped up. They had to be what's called kitted. They had to be put together in a kit and then married up with the vaccine by a distributor. And then that distributor had to get the vaccine and the kits out to the partner depots. Now, the partner depots, for the most part, are the states. And here, as we'll see, is where there was a problem. Because the piece that's very important, getting the vaccine into people's arms, depends on this right-hand side of the slide. When you have vaccine that gets out to these areas, such as a pharmacy or public health clinics or hospitals, you can read the other sites, that's where the rubber hits the road. And in fact, the federal government did not provide under Operation Warp Speed anything beyond delivering the vaccines across the state borders and then told the states, in essence, you're on your own. Now, we must remember, as I said, vaccines do not control disease. Vaccinations control disease. And to provide vaccinations to people, you need money and you need the people to do those vaccinations. So my son on his Facebook page, and he has a distinct need to require vaccine because he has type 1 diabetes. He's in a very high risk group. was disappointed because, as he said, there was no vaccine distribution plan, and that's true. Once the vaccines were delivered by Operation Warp Speed across the state borders, the states were on their own. Now, the Advisory Committee for Immunization Practices, an independent committee of the CDC, outside experts, came up with a prioritization scheme. Who ought to be first in line and so forth, second in line to receive vaccines? And their first tier was, as expected, were healthcare personnel, because they've been under the gun severely during the last year, as you know, and long-term care facility residents, because that's where the highest mortality was in our population. And then the other tiers you notice below that. Once the vaccine reached the states, however, the federal government said, you have complete authority to modify that, however you feel you should do it. This is how California came along with their plan, their allocation guidelines from the California Department of Public Health. They really weren't too different, but in essence, they made the tiers, they added tiers into the phases that kind of made it a little bit more complicated. And it made it complicated because people were starting to ask, well, what tier am I in? And do I really qualify? And, can I get this vaccine? So this is one of the disadvantages of not having a uniform national program to administer vaccines once they have been distributed, and using what's been called a federalist approach, where the states that have been under severe stress fiscally, as well as other ways for the last year in dealing with the administration of vaccines. Now, there has also been significant discussion about the best delivery strategies for this vaccine. In the trials that were done, 2 doses of vaccine, these are the Pfizer and Moderna vaccine, the messenger RNA vaccines, were given spaced out by either 3 weeks for Pfizer or 4 weeks for Moderna. A prime boost was the first dose, and then the second dose at that interval as a booster dose. And the data for that, as I showed you, were spectacular. I mean, this literally was a grand slam home run. The problem is we face a significant shortage of vaccines, because at the end of 2020, the vaccine manufacturers admitted that they did not have any stockpile. And in fact, they were cutting back on their estimates of how much vaccine they could make in the near future. So we were faced with the possibility that we would have to delay the second dose. Some countries, such as the United Kingdom, agreed, they reviewed the data, and they agreed that they could delay the second dose up to 12 weeks. In the United States, there was a lot of reluctance to do that by the regulatory authorities. There were various scientific reasons given for that. There are significant data in vaccinology to suggest that delaying the booster dose is not necessarily detrimental. And CDC last week did agree that if you had a situation where someone was delayed in getting their second dose, they could go out to up to 6 weeks without having to worry that they had transgressed the booster dose capabilities of the vaccines. Now, there was discussion about perhaps even, maybe we could cut the dose in half. But there was no data for that, really. The data were very, very skimpy. And fortunately, I think that particular vaccine delivery strategy has gone by the boards. So at this point, we're endeavoring as much as we can to give 2 doses spaced out the same as in the phase 3 trials. But we understand that if necessary, because of vaccine supply, it is a possibility to delay the second somewhat. Now, on January 21st, with 1 day in office, President Biden released his COVID vaccination plan. And it had 10 points. And the executive summary was very good. It's a 200-page plan, quite comprehensive. But They meant to do the following things: ensure the availability of safe, effective vaccines for the American public. That's essential. The second bullet is very important: accelerate getting those shots into arms and getting vaccines to the communities that need them most. Again, the communities that need them most is that ACIP prioritization scheme that I showed you, the Advisory Committee prioritization scheme. The Biden administration recognized that they needed to create as many venues as possible as needed for people to get vaccinated. You have to have a place to go. A country of this size needs multiple venues. There needed to be a focus on the hard to reach and high risk populations. The high risk populations are in that advisory committee on immunization practices set of phases. But the focus on hard to reach is important because we're not only a country that is very populated, 330 million people, but not everybody lives close by to a pharmacy. Not everybody lives within distance of a hospital or a public health center. There are many rural populations, and there are also populations hard to reach because they are vaccine hesitant. And that's a very important thing to focus on. The plan notes that we need to fairly compensate providers and also compensate states and local governments for the cost of administering vaccines. Dumping the vaccines across the state line, as the federal government did, without providing resources for states, counties, and cities to administer vaccines is a formula for disaster. They want to drive equity in this plan through the vaccination campaign and the broader pandemic response. And this is very, very important. We are not only a country that has 330 million people, but we have significant inequities, economic inequity, and we also have racial and other inequities throughout our country that, in essence, deprive certain populations of the speedy access to vaccine. And they have to be worked on and corrected very quickly. They recognized in this program the need to launch a national vaccinations public education campaign, which is being done, the need to bolster data systems and transparency for vaccinations, the monitoring of vaccine safety and efficacy as we go forward, so that these vaccines can finally be fully licensed as opposed to simply being allowed for emergency use. And they realized they needed to surge the healthcare workforce to support the vaccination efforts. As we noted, hospitals and public health authorities have been significantly battered by this pandemic. And it's very unfair to imagine that they can then take on, in addition to all they are doing, the vaccination effort without assistance. So again, just to recap what's needed. Well, we talked about logistics. We have to bring the vaccine that is here in a syringe and all the accompanying things in the kit, as well as personal protective equipment, together. That's the logistics part. We have to get people together, those who need the vaccine, those who are administering the vaccine. And we have to have a venue in which to do those things. The city of Los Angeles put out, for example, a website allowing for COVID-19 vaccine registration. This is a screenshot from that website. They did this in conjunction, setting up 5 clinics when they initially did it. There are more to come with the Los Angeles Fire Department, because the fire department has EMT capability, but also has a fair amount of logistic capability. And you all know, or you all have heard of the Dodgers Stadium site, which was used as a testing site as it began on its first day with people lined up to get their vaccine. And I just need to reemphasize, we're in the real world, okay? I hate to say this, but this is one of those things where you have to kind of make it up as you go along. You have plans, but as we say in the military, no plan survives first contact with the enemy, and you have to be flexible and you have to evolve and you have to learn quickly. You're going to hear, as you already did from Margan, experts may disagree. You're going to see this in the media. One expert may say we should do this. Another expert may say, well, we ought to do this. It doesn't mean any one of them are wrong. It just means that you can look at this very complex problem from different scientific perspectives and not entirely agree on what is perhaps the best way to do something. But the primary issue remains. What we really need to do is accelerate vaccine delivery for all Americans. Now, I put this up. This is from New York City. It shows their vaccination program from the middle part of December until the early part of January, about 3 weeks. On the first day of their program, they gave a grand total of 74 vaccines. When you set up a vaccination site, it's complex. Margan and I have done this in the military, and you learn literally minute by minute, hour by hour as you go along. Well, what's the best choreography to get this done efficiently and to move the largest number of people through safely through that program? So in the first couple of weeks, they were ramping up, and they got to some days where they had almost 14,000 people, but they had other days where they had none. And it turned out they were working during work hours on work days. And my point here is this is war. The nation needs to be vaccinating literally 24/7 if we're going to truly beat COVID-19. As Margan pointed out, we're in a foot race. I don't think viruses have feet, but we're in a literal or a metaphoric foot race rather with these variants. And to stop the variants from spreading and replicating and creating other mutations, we have to vaccinate our population. The United States has done this before. We were in a significant race with an enemy during the 1940s, with enemies during the 1940s, and we turned to. We ramped up. We did what was necessary, and it was an all-hands evolution. Body turned to with what was needed to meet that crisis. And I put this up because this is the League of Women Voters. My own personal belief is the world would be better if women ran it, but we can do this. It can be done. CDC put this graph up in their MMWR this week. I took it from them. And this is showing by the end of January, close to the end of January, where the nation was in terms of our vaccination program. And reaching as many as a cumulative in this point of 12 million vaccinations. But interestingly, if you go out a little further to February 3rd, we are now up to, as I showed you before, 27 million vaccinations. Now, the problem in the end, the trend line is upwards, but these are doses, these are doses per day, and you'll notice we're still under 1.5 million doses per day. There are many experts who believe in public health and vaccinology who believe that we really need to be vaccinating 2.5 million plus people a day to attain this goal quickly enough to outrace the virus. So we've got a ways to go. Now, what does the future hold? Well, we all sort of remember what it was like pre-pandemic. There we were out shopping and strolling around and gathering with our 10,000 closest friends in shopping malls, going with our friends to bars and restaurants and socializing. When we will get to this, I don't know. There's some hope that we will attain the ability to get to this in the summer or early fall of this year. I don't know that that's going to be attained, but there are many people more expert than I that believe that can be done. It's also important to have take-home lessons from what we've learned about this particular effort to contain this pandemic. This is what I call the Asian model. This is a photo from Taiwan. And in many of the East Asian nations, people routinely wear masks during respiratory virus season. And you'll notice there are some bozos who don't. We have more bozos in the United States than they have here. But we are seeing that this particular model pays dividends, and it pays dividends, and it's felt on a cultural basis, perhaps not as much on a scientific basis in the East Asian countries. But as I'll show you in a moment, between that and hand washing, something else we've relearned. Mom taught us to wash our hands. We've relearned it. It's a good thing. We prevent the passage of pathogens. And we should carry these things forward and consider carrying them forward even after this pandemic is done. And I think this slide is a graphic slide of why. This is data from Johns Hopkins, looking at the previous 5 seasons of influenza and RSV, which is respiratory syncytial virus, another respiratory virus, both of these transmitted both through the airborne route as well as through fomites. So both masks and hand washing and social distancing, they all have an effect on this. And these lines here for influenza and for RSV are the previous 5 seasons of these viruses. The red line is 2020, 2021, almost nothing. So as a side effect of what we're doing to contain COVID-19, and COVID-19 is, again, more difficult to contain because as opposed to these viruses, it's more readily transmissible through aerosols in the air. But you'll notice this significant diminution of disease. We didn't have an influenza or an RSV season this year. And of course, we've learned that some people in our nation can work from home. This guy has a relatively short commute from bedroom to office. He's still dressed in his business dress, at least above the waist. And your sartorial choices when you work from home are going to be different. You can come in your pajama bottoms, just don't stand up in front of the camera. So we're going to have a world that's changed after this pandemic is controlled. And finally, the good news. This is from Israel. And Israel is a small country. It has an integrated health system that is a governmentally funded system. And this is looking at people who were vaccinated here at day 0 and looking at the daily positive test positivity for COVID-19 and the hospitalizations for COVID-19. So when everybody was vaccinated, it was primarily the green line here that was vaccinated. The green line represents the older Israeli population who were targeted to get the vaccine first, as opposed to the blue line, which included primarily younger people. In essence, you didn't see any difference until, just like we saw with Pfizer and the Moderna data, after about 13 days, there was a significant diminution in COVID-19 positivity, test positivity, and also a little bit of a lag, a diminution in hospitalization. So this is real world data with a larger population that these vaccines are not only efficacious in the trials, but effective in large populations. And as of the 1st of February, the latest data I had on this, Israel had gotten vaccines out to almost half of its population. It was about 49.3% overall. Some people got 2 doses, but it meant that overall, half of their population has received vaccine. They're far in advance of the United States at 9.4 and the other countries that you see. And again, one last piece from Israel. The light blue bars are the older Israelis. As of January 2nd, the critically ill population among older Israelis with COVID-19 between January 2nd and January 9th, as they were getting their vaccine program rolling, indeed was no different. However, you'll notice this significant diminution within a week after that. So the vaccinations not only prevent disease, they prevent severe disease, critical illness, and the need for hospitalization. Now, I want to close with this. I said a little bit about inequity, and I came across some numbers this morning, literally. In Florida, in Dade County, Fisher Island is a zip code that has exactly 400 inhabitants. It happens to be the wealthiest zip code in the United States, median income greater than $200,000. 51% of those people have gotten vaccine. Opelika, which is very nearby, has a population of about 32,000. 1.4% of them are vaccinated, but the median income, again, equity is an issue. I'll close with this slide because it's an equity issue not only for the rich countries, we have to solve it for ourselves, but for the world, because as long as there are people on the planet, large populations who are not vaccinated, they represent a reservoir for this virus. And when the virus replicates, the virus creates new variants, and then we're going to go back through the vaccine cycle. So we'll close here. I'll stop sharing my slides and we'll take questions.
Thank you, Thad. I'll take a few minutes and let you catch your breath. We're short of time, but we have a number of questions, and I think probably I can knock off a number of them pretty quickly. The first one is about opening schools without teacher vaccination, and I'm sure everybody realizes this is a very controversial subject. I'm a longtime member of the American Academy of Pediatrics, but I have to say that I don't completely agree with their stance. I think that politically and morally and compassionately, it would be a really good idea to immunize teachers before schools open. But I can't argue that the data do suggest that if the NPIs are well instituted, that transmission is very low in that setting. The next question is about the use of zinc in COVID-19, and I know that there are many people that swear by this, but I am not aware of any randomized double-blind placebo-controlled trials that suggest that zinc has any efficacy in this disease. The next question is a question about why some people die and some people have only mild symptoms when they get COVID-19 infection, and that's a superb question. It's a question that I have wrestled with for more than a year now, and I was greatly relieved when I saw somebody in an interview ask Tony Fauci that question, and the short answer he gave was he doesn't know. So I figured if Tony Fauci doesn't know, then I shouldn't feel so bad because I can't figure it out either. Although it does highlight the fact that there's a lot about this virus that we still don't know. The next question was also a good question. It's a question about the fact that LA County is having trouble with reliable supplies of vaccine. And does that mean that people should wait for the first dose till supplies are better? And the short answer to that, at least in my opinion, is no. You should go and get your first dose whenever you can. It's likely that you will be offered your second dose on time, so to speak. But as Thad pointed out, if the second dose is delayed, there is no downside to that. And in fact, there are some new data that suggests that there might be a little bit of upside associated with widening the interval in between. So if you get your first dose now, you will probably you will then start to enjoy somewhere between a 50 and an 80% efficacy associated with only that dose. So you should get it now. The last question I have here is about why healthcare workers some of them are refusing vaccine. And it's important to point out that not all healthcare workers are the same, and they tend to reflect the distribution in the general population frequently. And they are also subject to social media memes, the same as everybody else. And in fact, some of them carry some really difficult baggage from abuse in past decades from research. And so I don't know that we should necessarily be surprised by that. Although I must admit, I was taken aback by seeing yesterday that 55% of the firefighters in Los Angeles County are refusing the vaccine, which is not a good thing. Now, maybe I could ask Thad a question. We have a question for him. This question is about, this person says they got their first shot from Moderna. They didn't have any side effects, no redness, no nothing. Does this mean that there's something wrong with their immune system?
No. When you look at the data from the trials, there were a large number of people in the trials who had no significant reactions, either locally, such as a sore arm, or systemically, such as headache or fatigue, or fever or chills, after dose 1 or dose 2. And yet the efficacy of the vaccine was 95%. So the fact that your immune system is not a diva and doesn't produce a significant response where you sort of feel like you've been perhaps had a touch of the flu doesn't mean that it's not working. It just means that's your immune system and that's how you're responding. So the answer is no. If you should count yourself happy if you don't have any symptoms. If you do have symptoms, you can say, well, that's just my immune system.
Okay, another one for you, Thad. This is, how much can Pfizer and Moderna change their vaccine before they have to do a new phase 3 trial?
It's a very good question. And most experts have considered this kind of like influenza vaccine. They're totally different viruses, but we've been using influenza vaccine for a while. And we know the safety profile of the vaccine. The safety profile does not have to do with the exact sequence of the messenger RNA. It has to do with how you put the vaccine together. So in essence, what would have to happen if there's a variant that now is, that shows any immune escape, you would have to go ahead and make a new vaccine. That can be done literally within several months because of this new technology, this mRNA technology. And what you would then do is you'd probably give it to about 100 people or so, a small phase 1 study, enough to show that it produces an immune response. You would not have to go through the gigantic phase 3 trials that we have seen this past year for these vaccines.
Okay, the next question is an amalgam of several questions for you, Thad, and it really relates to how long will the Pfizer and Moderna vaccines be efficacious? Will we have to get new vaccines in 6 months? How long will immunity last?
So the data now we're going far enough out from the trials that we know that the data show that the immunity with antibodies certainly persists for months and months. We also know that from people that have had COVID-19 infection, where you can show that immunity to reinfection goes on for months and months. Now, it doesn't mean that reinfection doesn't occur, but we should remember that documented reinfection with coronavirus that causes COVID-19 is very rare. It's not common. So I think that the best we can say at the moment is this immunity goes on for months and months. We may get to a point where we have to administer boosters to this vaccine. We don't know that yet either. But if you are vaccinated or get vaccinated in the near future, I think you can count on months of immunity from the COVID-19 virus.
Okay, thank you. There are a couple more questions here that I think can be knocked off pretty rapidly. One of them is, if one gets a single or 2 vaccine shots, should that result in a positive COVID test? And the answer is, if you're referring to the rapid antigen tests or the PCR tests, the answer is no. In addition to that, a sort of a related question is, after I get my second Moderna shot, are there tests that prove I have personal immunity? The answer is yes, there could be. Those are tests that are usually done in an academic research setting, and they are not recommended for the general population. There's no reason to suspect that people will not mount personal immunity if their vaccines are appropriately administered. The next question has to do with taking ibuprofen before the second dose, or in fact, for that matter, before the first dose. And the bottom line is that non-steroidal anti-inflammatory drugs are not recommended to take prospectively before you receive the vaccine. It is probably okay to take them afterward if you're not feeling particularly wonderful after receiving the vaccine. I personally would recommend the use of Tylenol under those circumstances because its anti-inflammatory effect will be less. You do want some inflammatory response because that tells you that your immune system has recognized the antigen it just encountered. Let's see, I don't know that we have any, well, we do have some more. Do we know anything more about the physician in Florida who died within 16 days of receiving the vaccine? Well, I noted that as well. That was a somewhat disturbing event. There's no evidence that I am currently aware of that this catastrophe that occurred in this physician, he developed an autoimmune thrombocytopenic purpura right? There's no evidence that it was specifically related to the vaccine that he received. I'm sure that there were autopsy findings that are going to be studied, and I have seen nothing further about that particular case. I don't think that it says anything about not receiving the vaccine, which has now been received by millions of people, and I am not aware of any deaths attributable to the vaccine that have occurred since then. Let me look and see what other questions. Question is, are people with autoimmune disorders at more risk with the vaccine? And the answer is, I'm not aware of any data that would suggest that is true. There was also a question about older individuals who have been vaccinated congregating. That's a difficult question. It's a question that's going to be addressed in a variety of different venues, including the place where we live, where the residents who have virtually 100% of them have been vaccinated are all going to be very desirous of congregating. I think that if everybody is vaccinated and you're relatively sure of that, then it's okay for them to congregate. But I think that it does mean that everybody has to keep an eye on these variants, and we have to be prepared that even if we loosen up a little bit with regard to restrictions right now based on receipt of vaccine, that we may have to tighten back up again depending on having a surge with a variant with immune escape. I think that pretty much covers most of our questions. There are a couple of them that are really intended for a research virologist, and I can answer those questions as via email to that person. So maybe I should turn this over to Martha Zavala at this point.
Thank you. Thank you so much for that information. I know that we've all really been paying attention to what's going on with COVID, which is the disease, and how you explained, you know, the real okay, apparently. Anyway, I hope you can still hear me. That we've all been concerned about we've all been concerned about this all this information that's out there and what's true and what isn't. So I really appreciate all the work that Margan and Thad put into this presentation, and I can tell how interested everyone was because you're all hanging in there with us. I know we had hoped to wrap up our program by 11:30, but I really do think that this is such an important uh, piece of information, and to help us feel really hopeful about what's happening. But we have to do our part, as they mentioned. You know, just because you've been vaccinated doesn't necessarily mean that you should go out there. It doesn't say necessarily that you're not going to contract the disease and maybe spread it and carry it out to someone else. So we have to hang in there, you know, for perhaps another 6 months, maybe even another 12 months, because we need to make sure that we're not adding to the problem. I think we all have hopefully figured out how to well, bunker in our homes, and might need to continue to do that. I think they said, you know, if you know that everybody in your group has been vaccinated, it's been 2, 3, 4 weeks since all of you have had the vaccine, and then you know for sure your immune systems are good, then the likelihood, if you've all been sheltering in place and not going out into the greater community, that there probably isn't that big risk for you to congregate. So I think many of you have that to look forward to, and that's really great news. Again, thank you very much, Margan. Thank you to our events committee, um, and for setting this up, Catherine in particular, who's played host to organizing all of this. Thank you. I do have another announcement that I'd like to make, that we are going to, in fact, have some other events coming up. And so we would like you to join us. You can go to our website. We will then update where you can get the link for our March 4th Thursday with the League. It's about the new directions for immigrant rights. And we will have a representative, Apolonio Morales from Churla, who will be there to speak to us about that. So please come back for that. And then we have another event that will be coming up in March, also on March 18th. And this is an event that's a league at night. So many of your friends may appreciate this. And this is related to something that all cities have to have, and that is they need to have climate action plans, programs put into place about how they're going to combat climate change within the city boundaries. We're going to have a representative from the city of Pasadena that's going to be talking about their plan. So we're very excited about that, because that's another big issue that we all as a group need to commit ourselves to combating the effects, so that our children and our children's children will have a climate that is still, you know, conducive to enjoyment, to have us be outdoors. My biggest fear is always the wind. You know, it can rain a lot, and it can be really hot, but you know, we've had quite a bit of destruction in our backyard from the wind that's come with it. And so I think it's a really great program for you all to be aware. And if you're not from the city of Pasadena, as I said, all cities are required to have these climate action plans. And so it would be good for you to come back and join us and see what it is that the city of Pasadena is doing, and then turn around and look at your own communities and look at your city council and find out what they're doing within the boundaries of your city, because there's a lot that can be done. We're not committed to having this happen. And let me finally thank you all for joining us this Thursday and hanging in there with us to get this really great information from Thad and Margan. And have a great day. Have a great rest of the week, and we'll see you next time. Thank you.